Hello, I am Dr. Aziz. I am the Chief of Pathology at St. Vincent Cancer Center. When Dr. Konde visited the center, Dr. Konde and Dr. Jagannath asked me to review the pathology of this patient and highlight the pathology and the morphology of this case, and that's what I'll be doing now. The patient initial presentation was with a bone marrow showing nodular involvement of the bone marrow, but the bone marrow aspirate was only 8.5%. This is a section from the bone marrow, and the bone marrow showed this nodular involvement of the bone marrow, only patches of plasma cell. As we see here, it's solid sheets of plasma cells, and they are mature, meaning they are very similar to the normal mature plasma cells. The only difference here in these cells is they are slightly larger in size, and more important is the monoclonality, because those cells are positive for kappa and negative for lambda, indicating these are actually monoclonal cells. And the bone marrow aspirate, there was a little discrepancy here because we are not seeing in the bone marrow aspirate as much as we see in the bone marrow section. Now the question is, which is better, the bone marrow biopsy or the bone marrow aspirate? In fact, it's recommended to do both because there is value for the aspirate and there is value for the bone marrow biopsy. One thing we know about the aspirate is we need this for the flow cytometry study, but we have to be aware of the problem with underestimating the number as it happened in our case. A bone marrow biopsy is important. Beside the architecture that help us with the diagnosis, we need the bone marrow for immunohistochemistry. When we have a case of a differential diagnosis and we apply various antibodies against the bone marrow, we also need the bone marrow when we are investigating amyloid, and we can apply Congo Red for examination of amyloid. And not only this, we can also study the lysis of the bone by studying the morphology of osteoclast and the reaction of the osteoclasts with the bone marrow trabeculae.